I'd like to Bill Clark with StarTech has the list. He has the list of codes that they're ABC codes for alternative medicine that supposedly are going to be used and help patients get reimbursed for some of their alternative care. So you can go to the StarTech table in there, and Bill Clark will have some sheets that have a preliminary list, and then they want us to add procedures to those to the exist that they already have started. Two other items. HIPAA compliance. We're not starting that. It's not our idea, but as dentists, we need to comply, and we're not going to have a choice about complying. Nick Meyer reminded me of this, talking about the fines can be up to $500,000 for not complying with the HIPAA regulations. The deadline is March 14th for the privacy portion of that act, and October 16th for the security portion of that act. This is just a heads up about something that's going to affect all of us that we need to pay attention to. If you don't know about it, when you get home, check with your dental supplier or somebody like that, and they'll be glad to tell you all about it. Yes, sir.
Serious about this, and the government. If you get a complaint filed against you, you're not even supposed to have a schedule up with people's names on it. If SoftBank has come out with a update on their programs to try to be HIPAA compliant, and you can't even tell, we don't even know what procedure we're doing on the patient off our schedules anymore because it's HIPAA compliant. Ignorance. And I would suggest everybody write their congressmen and senators and say how ridiculous this thing is.
Thank you. Excuse me?
I said in the meantime,
Be HIPAA compliant.
Yeah, until then, comply, because it's not a choice they're offering us. Our next speaker, Chris Simmons, is a neuromuscular dentist from Seattle, Washington. He has an emphasis in his practice on jaw dysfunction, and he has a separate business and practice, which is he's owner and operator of Seattle Maxillofacial Imagery. He's going to be talking with us about a new technology. Please give him your great attention. Thanks.
No. It's a little glass here. Well, first of all, I'd like to thank the directors for inviting me to come and do a presentation at this meeting. This is my first attendance at this meeting, although I've been around the sort of the holistic realm for quite a while. I worked with Hal Huggins back in the late 70s, early 80s, and so I'm very familiar with much of that, and have oriented my practice in that way for a long, long time. Secondly, I want to say, as a way of a disclaimer, or disclosure rather, that I am the owner-operator of an imaging center which uses this technology. However, I'm not here selling any product or really promoting a product, and I have no affiliation with Aperio Services, which is the United States supplier of this product, or with QR of Italy. So what I'd like to also ask is that I'd also like to apologize that unfortunately I'm not going to give you a treatment hint or a therapy or some great technique that you can take home with you, on Monday morning and begin to use it on your patients. This is sort of a heads up of a technology that you're going to be hearing more and more about. It's beginning to show up in journals and other articles. It's, I believe, a revolutionary change in dental imaging. Dr. Hatcher, many of you know, in Sacramento, has said that as far as he's concerned, this is the greatest advancement in dental imaging since we began to take dental films. So I think you'll keep an open mind about what I'm going to show you. I'm also not promoting any particular treatment or therapy based on these images. This is to give you a brief introduction to a new type of dental imaging possibility. This is the Newtome 9000, which is a cone beam volumetric tomographic scanner. This is not a medical CT device. It was especially designed and engineered from the ground up specifically for dentistry. So there's significant differences, which I'll be going over and explaining here in my presentation. The Newtome technology is able to three-dimensionally image any area of the skull and the upper cervical spine, all the parasinus spaces, and the airway. So the benefits of this technology to the patient is, as I'll explain, is reduced radiation exposure, much less chair time. The total time from the time they enter the center, fill out their paperwork, position in the scanner, receive the scan, and are dismissed with a walk-away insurance form is about 10 minutes. An improved visual communication tool, in other words, the patient is, in my experience, much more easily able to understand the treatment objectives, the diagnosis, and the problems associated with that when you're using this as a communication tool. And you're able to also receive multiple reports from a single scan. So for a medical CT, for those of you who've used medical CTs, I've been using them for about 14 years now in my practice. I no longer use them, by the way, but when I ordered a CT of an area, what I got was the CT of the area that I requested, and that was all that was available. If I wanted another area to be looked at, then I had to order another CT, and on this went. With Newtome CT, you can image the entire upper and lower jaw, sinus spaces, upper cervical spine, and you can have as many images as you want. It's infinite images can be reconstructed. Doctor's benefits, again, are a better visual communication tool, communicating with your patient. This represents the optimum in forensic documentation that exists radiographically in dentistry. And a huge body of diagnostic information with a single very low dose scan. Now this concept, cone beam physics, is involved. You may know medical CT is a process which involves continuous slices from the top down, 1 millimeter thick slices, so that you end up with a stack of images, computer digital data which is then reconstructed, and there is a special mathematical algorithm to reconstruct those. With cone beam volumetric radiology, what occurs is there is a receptor here. The patient is reclining with the head inside the machine. It's shallow, so there's no claustrophobia. And then the X-ray source moves around the patient. This rotates around in 70 seconds. You get 360 exposures. And each exposure, rather than taking a slice, is an exposure of the entire volume in that space. So in that sense, it's kind of like taking a lateral cephalometric film. When you take a lateral cephalometric film, you expose the entire volume. It's compressed flat onto a screen. So in that sense, it's similar to what we normally look at. So this captures 360 different images as it moves around the structure that you're trying to image. So the raw data is then converted into a 3D reconstruction algorithm, which creates a 3D voxel reconstruction matrix. And then out of that, you can bring any sort of two-dimensional image or three-dimensional reconstruction area that you'd like to see. And what is the pointer on this? Is it oh, I see, it's late. Oh, got it. So the main features are good efficiency in the longitudinal volume coverage, very low X-ray source load. There is no continuous rotation. There are small reconstruction volumes are possible, and it's suitable for low price in the instrument itself. Low price is a relative term, of course. This instrument now is about $300,000. So, I mean, it's you might want a six-pack of these. One for each room. So this is just a X-ray source load comparison, comparing CT spiral, for example, with in milliamps with cone beam technology. So you can see here that there's considerable difference in. This is the machine again, in case you didn't get a look at it. First of all, this is very shallow here. The cone beam rotation device is in here. The table slides both in and out and up and down. You can position the patient using two-dimensional laser positioners that allow you to locate the patient very rapidly. And then the patient's head is just, this is about, maximum depth here is 14 inches. So it's not a problem for people who are claustrophobic in MRIs and those kind of things. Completely different. This gives you an idea of the clarity. As I said, this was designed for dentistry specifically. One of the problems, if you've been using medical CT to do dental diagnosis, you know that the dental structures and dental restorations completely blast the image. So a lot of the areas of the mouth are the regular CT scan images are not usable because we can't make out what they are. And this person has a upper and lower RPD, you can see. And this is what we call the lateral scalp view. This would be an initial view in positioning. This is what we would see on the scalp view when the patient's being positioned. So we get one from the side and then one front to back to position the patient properly in the machine. Now, based on the acquisition, then we can begin to do a reconstruction of the area that we're concerned with. This image here is a scalp reconstruction. So we can look at the steep plane angle on this mandible. Obviously, we want to reconstruct parallel or perpendicular to structures that we actually want to look at so that they're not distorted. So this is just part of the technician's job. Once the image is acquired, a technician has to actually sit down and go through some computer processes to reconstruct these images. So these represent standard views of what we call axial views through the mandible and through the maxilla. And so you can begin to get an idea just as we go through these images. I just ask you to notice and observe some of the things that we're looking at. This is a 1 millimeter thick slice. So you cannot look at these like we do our normal dental images because we're looking at small slices. We can go from 1 millimeter, we can go actually from 0.2 of a millimeter slice image to 14 millimeters thick, which is more like a traditional pan, let's say. So you can see the root canal spaces can be seen very easily. Actually, we look at a lot of these for endodontists. Again, I'm not promoting root canals or discounting them. I'm just telling you what the images can produce for us. The sinus spaces are easy to examine. The airway can be examined precisely, and there are great advantages in each of these areas that are only possible with this kind of technology. These are transaxial cross sections of the mandible. So this is how reconstruction would appear, for example, on a report that a dentist might get. This is the mandible. These are the transaxial slices. They're 1 millimeter thick and they're numbered, and then they appear on the page numbered here. So very easy to locate anatomical structures. For example, the mental foramen here. You can track the route of the mandibular canals very easily to locate. And it's very interesting, having observed hundreds of these now, it's very interesting the anatomy that we see here that's completely different from what you might expect looking at other films. These are our panoramic designs. Again, keep in mind that these are not a typical panoramic film. So this image is a 20 millimeter thick film here, and a 3 millimeter thick film here. So when looking at these images, you might mistake an area of for some pathology here. It takes a little bit of studying and understanding what you're looking at. And then the three-dimensional views that we can reconstruct. These are obviously various segments, and we have the ability to peel away layers of bone here. In other words, it's as if you were dissecting away a millimeter or 2 or 3 millimeters at a time. So you can actually go inside internally into these structures, looking for lesions in the bone, looking for impacted teeth. For orthodontic diagnosis, three-dimensional diagnosis allows us to go internally and actually locate anatomical structures three-dimensionally. You can see cavities of the bone, absolutely. Radiation exposure comparison, it's probably, this group is very concerned, but it's interesting to me that very few physicians or dentists that I talk to have any concern whatsoever about radiation exposure. I mean, this is not a selling factor for the new tome to the practitioner, but it seems to be something the patients are very concerned about. New tome scan absorbs 40 to 48 international service of radiation. Radiation exposure is measured by the most dense profile of the skull. These studies were done by Hatcher and others, Danforth. What they did was they took basically a plastic head and drilled holes through it in various places to locate the positions of normal anatomical structures that might be sensitive, and then they exposed this head to different levels of radiation by different machines. So you're able to measure the exposure that different tissues are receive. And in the new tome technology called smart beam technology, the radiation is measured by the scalp beam automatically, measuring the most dense profile of the skull. Then it averages the exposure to the entire skull, or the entire area that you're imaging, would be 50% of the maximum exposure measured on the most dense profile. That's the most dense area of the area that you're imaging. And this profile is approximately 1/4 less dense than that of the most dense profile. So what does this mean? Well, this means that we can adjust the radiation during the entire 360-degree rotation relative to the tissue density that the previous scan encountered. In other words, 360 times during this 70-second rotation, the radiation exposure is adjusted so that each radiation exposure is optimum for that particular patient. And this is a proprietary to this instrument. It's called smart beam technology, which also means that there is no adjustment that the technician can make in that. So you can't just go in like we can go in and set our dental x-ray periapical units. You can't change it on this system. It's all done by the computer. So you can't override the computer and go set your own exposure level. Makes this very, very safe. And as a result of that, this was actually classified by the FDA as a dental device, dental imaging device. So it is possible then to have your dental auxiliary staff actually operate this. We don't have to have a special licensing. This is just a table that is a result of Hatcher and Danforth's work comparing Newtome, the Newtome effective mandibular dose using the smart beam technology. Newtome delivers 20 to 24 international sieverts of radiation. Compare this to standard tomography, CT tomography. I mean, this should be very obvious to anybody that, and this is one of the reasons, by the way, the physicians are reluctant to use CT. So, for example, to look at sinuses, patients go back and back and back to the physicians, and they're getting sinus treatments, but nobody's ever looked at their sinuses to see what's actually, what are they actually treating, or is there anything in there to treat? But they keep giving them antibiotics and other therapies and decongestants. One of the reasons they're reluctant to is because of this. This is huge. Panoramic and an intraoral series. So we're about 1/4 of an intraoral series, for example. So in my practice, I no longer do a full mouth intraoral series. So if a radiation exposure is extremely low for the amount of data acquired, it's huge. In addition to the fact to consider that with one 70-second beam, we can generate all known dental X-ray views, whatever you would want, can be generated from one scan. So if you're taking joint tomography, let's say, well, maybe you got an orthodontic patient, maybe you need to know about the joint, you're going to do joint tomography, you're going to do lateral ceph, you're going to do frontal ceph, maybe a lateral ceph with and without an appliance, maybe you're going to do some PAs, maybe you'd like to see the sinuses, on and on and on. How many images would be required in standard X-ray? First of all, it would be over $1,000 probably to acquire those, but secondly, it would be a huge amount of radiation and a lot of time. So we can do that in one 70-second scan. So that's pretty exciting.
You'd have to do different things if you're going to have a rest.
You have to do two different ones if you're going to alter the position. Yeah, most of these are done with teeth together. They can be done with an appliance or a stent. I think we have some of those in here as well. Distortion comparison, and this is something that I think is very interesting because, you know, we've used periapicals have been the standard, and panoramic films have been incorporated into dental practice for years. My very first opened my office 25 years ago, I had a panoramic machine. And since it's become so commonplace in dentistry to have this kind of instrument, and it's used so frequently, I think over the years what's happened is we've grown complacent, maybe that's not the term, but we've overestimated what we've been able to glean from a panoramic film. And I just heard Danforth say that at the last meeting of the American Academy of Dental Radiology in Chicago, one of the lecturers there made the statement that a panoramic X-ray film is about the most useless thing you could have in your diagnostic armamentarium. You possibly can count all the teeth, and you possibly can tell if they have a complete upper and lower jaw. But other than that, the distortion is so huge, the magnification is huge. The orthodontic board in California now is considering dropping the panoramic film from their board examination requirement. And the reason is that the distortion is so bad you cannot even tell if the teeth are parallel or not. So for many, many years they've been passing people who didn't have parallel teeth, who thought they had parallel teeth, and they've been failing good technical orthodontists who were doing a good job, but the panel said they weren't. I mean, it was all a factor of what kind of panel did you end up with and how did the patient get positioned. You pass or fail your entire board exam. That's the truth. So, so we know that all these images have an enormous degree of distortion, and I think that's an important thing that we sometimes forget when we're looking at those films. We think that's what we're looking at on a film is like it's a picture. Picture's worth 1,000 words. Pictures don't lie. But X-rays are enormously distorted, all of them. So in the new tome, there's virtually no distortion. It's 1% or less. So what you see on the new tome is what you get. And that creates a problem sometimes as I'm consulting with dentists and physicians because, well, dentists especially, because they don't always know what they're looking at. So they're calling me wanting to know, well, I'm seeing something here on this X-ray. I don't believe what I'm seeing. But you know, the answer is simple. You're seeing exactly what's there. If there's a hole, there's a hole. It's not a make-believe hole. It's not a hole that maybe you just think you see. Maybe you have to hold the light different, or maybe And it's surprising how many dentists still hold these pieces of paper. This print's on a piece of paper. It's not an X-ray film. It's a piece of paper that you can look at. The dentists still hold them up to the light. I guess they're trying to see something better. So this is, of course, our standard panoramic film that we've been looking at for years. Well, does anybody here really think that anybody's jaw looks like this? I mean, that looks like, I don't know, Australopithecus giganticus. And I don't think they were doing root canals back then. And where would you guess these cuspids are? You have no idea, really. So this is a new tone pano, 12 millimeters thick, which approaches more what we're accustomed to looking at. And this is just an example of what they look like. But obviously you can see here, there's no question here, what's going on. That's not a shadow. But what happened to their teeth? I mean, they have teeth here. But this is a vertical cut. This is a precise vertical cut this way. So that's why I said you have to get accustomed to reading this. So when we generate a pano study, we'll generate several cuts so that the dentist gets a better view. Also, this is not the only cut that the dentist gets. So again, you're thinking three-dimensionally. Interesting panoramic image that you probably haven't seen before. This is a sinus panoramic image. And obviously you can see the problem here. There's a little bit of a root canal thing there. So these are just examples. This is an image that you won't see anywhere else. This is an image that we developed using the new tome, just the computer software technology. It's a great screening tool. I like this better than anything. And in fact, I like these coronal views. These coronal views of the jaw joint, I think, are going. We're just now working on what this all means, but you'll see some examples later. But this gives you a real quick visual on the report. When you look at it, you can see, well, right compared to left, what does it look like? You know how hard it is to hold those little tomographic things up, and you're figuring, well, I don't even know what's right and what's left, and you have to lay them out, and it takes a little while. And even for people who've been doing it a long time like me, or maybe my wife tells me I don't know my right from my left anyway, so I guess maybe that's why. So we can also render volumetric data into specialized types of lateral head film. So this is going to change the way that we do what's always been called septometric analysis. Is going to have a significant revolution here soon. This has already been worked on in Italy. And those of you who followed David Hatcher's work perhaps know that he, for many years, was working on three-dimensional imaging using multiple projections of cephalometrics from different angles with markers, anatomic markers placed on the subject. And you would project from different angles, and this could be reconstructed. And he spent actually quite a bit of his life and time and money on that effort. But when he saw the new tome, he immediately abandoned all of his research entirely, just flushed it. Sometimes technology, propels us forward quicker than we're ready to be propelled. So he's now using the new tome, actually. So here's what we're able to do with the soft tissue. So this is a computerized reconstruction of the soft tissue. Now, We can also superimpose the soft tissue over the internal images as well. This just gives you an idea what the detail is. This is not a photograph. And we can create a bilateral cephalometric image, same patient. This is the more traditional cephalometric view. Structures superimposed upon other structures, both right and left, that we're accustomed to looking at. So if the doctor wants a lateral cephalometric of traditional, then this is it. We can also do what's really going to be more significant now is we can create a lateral cephalometric of half of the head. So the right half and the left half. And those of you who've done cephalometrics realize why this is significant, because the right half and left half are never the same. And so what we're typically doing is averaging. We're averaging everything. This is going to make cephalometrics considerably less of an art, more of a science. It's always been kind of an artsy thing. Any two people, myself, I sit down and do the same cephalometric film twice in a row. I won't put the points in the same place. I defy anybody to do that. So certainly 10 different doctors doing the cephalometric are not going to accomplish that. Orthodontically or oral surgery for maxillofacial surgical procedures, we can evaluate the alveolar heights. It's the same patient. You can see a comparison. For example, if we need to know, and there are many. I have an entire PowerPoint presentation just on orthodontic current limitations of orthodontic diagnosis and how it affects your treatment plan. So I'm not going to get involved in any single program, but if you need to know, if you're going to move upper incisors, you need to know where those upper incisors are. Soft tissue front, pretty nice for an X-ray. When you say, you see all the features that you need to see to do a soft tissue analysis cephalometrically. And keep in mind, this is all done from one image. So the frontal cephalometrics. And three-dimensional bone rendering. So now we can begin to see where these cuspids are. How many people have seen cuspids come in the palate? Well, on the pan, you don't know if they're in the palate or where they are. And we could peel the bone away a little bit. And we can see a little bit more of the root orientation, what's going on in this area here. It's a way to dissect your patient's head without having to kill them. Most of them are reluctant. And the rear view. Another thing that we're doing is we're actually able to use three-dimensional milling and create models, upper and lower models from this image. Cool, huh?
You doing that now?
Doing that now. I'm not doing it in my lab just because we haven't had requests and something else I got to buy. I'm exhausted from buying stuff. My wife's she would divorce me, but I already spent all my money, so. She's going to wait till this thing makes me some money, and then she'll divorce me. So this is our standard TMJ view that we've all seen before, and we all know what those are, corrected tomograms. And that's what we typically get, back from our center. Maybe you get 6 of them. Maybe you get 1. And this is what typically, on a study, we'll get a series of views like this. So right and left. These are 1 millimeter slices, so the detail is quite a bit better. Actually, this patient looks pretty normal on this image. A slight bit of distalization, a little bit of osteophytic formation here, and here in this view you can see that they actually have degenerative joint disease in the lateral pole and moving toward the medial pole, it actually clears up, which is pretty common. And here you can see the same joint. Critical in these kinds of TM images, why I think these are so important, is that what we've observed is that patients with a steep lateral aspect to the glenoid fossa, these people can brux their entire dentition away, and they won't pop and click. They don't get jaw joint problems. But people who have this steep eminence here, they typically blow out this lateral pole and measly displace the soft tissue. Now, this is not a soft tissue instrument, actually, but we can get some soft tissue images, and you can see right here. Here's the disc here. Yes. So we cannot always see it, but we can sometimes see it. Here's another view. You can see the steep eminence here. So there's quite a bit of anatomical variation among people, which shouldn't be very surprising. Upper cervical spine. We can also slice through this in 1 millimeters, up and down, back and forward, or sagittal. Doesn't matter. You name it. All you have to do is ask the computer to do it. We also get excellent. I've had a neurologist and we have a specialist that I work with in Seattle who's a auditory neurologist, and he's come down and looked at our views of the inner ear, and he says there's no medical instrument he's aware of that gives you that kind of clarity. You can see every bone, just as if you're doing an anatomical dissection. So here you can see the disc here as well. And obviously a pretty badly beaten up joint. So this is just showing you different kinds of images that we can construct. This is a TMJ view that revealed osteoarthritis of the left condyle. Was not visible on any tomogram that had been taken just prior to this. So this is a normal situation. Adequate spacing. Fairly nice eminence anatomy here. Another interesting thing we're finding out that often, we've been looking at condyles for years and years and years, but what we're really seeing is that before you see any change here, this begins to go. And you're not going to see that on a tomogram at all. This begins to go here. You can see here there's some change. You see that's a disconnect in the bone there. That's not any kind of artifact. That's a 1 millimeter slice. And that's not artifact. That's a hole. That's a hole in the bucket. So here you can see this is an area of osteoarthritis. And this was not visible on the tomogram. Because, again, you superimpose structures. So some things you're not going to see. It's going to be really beaten up before you see it. Osteoarthritis of the left condyle, same thing, not visible on tomogram. Can you see why that might not be visible on tomogram? And you can look and see the changes in the irregular surface now of here, and close proximity of the lateral pole to this steep lateral eminence. And this patient had a lot of popping and clicking on this side, but none here. And here's the disc position there. Here, so another view. Yes?
Since you do a lot of TMJ-type treatments, are these the kind of patients that, as adults, if you put into a repositioner, sometimes they exacerbate their pain because the maxillary component isn't wide enough for the mandibular component to come forward?
Well, if you're using a sort of an arbitrary anterior repositioning appliance, is that what you're asking me? Will that happen if that's your...
The doesn't have to be anterior, just repositioning is fine.
Yeah, but it, you know, you have to do a more complex evaluation before you put your appliance in. I think that's the key to it, and Dr. Carl Gugino taught me that early on in my career. He said, you know, diagnosis is 80% of your treatment. If you don't get the diagnosis, and you just wasted your time on whatever you did for treatment. So in my practice, I can honestly tell you that I've never had a single patient get worse, period, with treatment. Never. Now, Monday morning, I'll probably go back and just put a curse on myself, but I hope not. But there are diagnostic criteria that you can use to prevent yourself from getting in trouble in that regard. Obviously, if you take an injured joint and you strain it additionally, you're going to cause more pain. I've been doing a lot of work for the endodontist. I think they're going to be calling on me a lot more after Bob's paper comes out. I'm going to be flooded with those guys. Well, they don't want to look at this. I mean, they don't want to see these images. They kind of do, but they kind of don't. So these are sagittal cuts. These are 1 millimeter sagittal cuts, typical of part of what we would do in an endodontic study. And what you see on these cuts, you might think, well, you know, why wouldn't you see this on a X-ray film? See this area right here? That's a hole. That hole, an oral medicine specialist, 2 endodontists, a general dentist, all took about 87 films of this, which, you know, probably was, they were trying to cure it by using radiation therapy, I think, but none of them actually, none of those films showed anything. The tooth was symptomatic, but when we took these images and showed them, and then they were looking at the films and looking at these images side by side, so we knew exactly where to look now. No question. We know where we're looking. It's still not there. So this is what we see commonly in these endodontic problems. This is a 3-dimensional view of the same area. You can see the hole right here. This is what we call transaxial. And just while we're here, you know, you can see where you're going with root canal fills. You know, when you look at a view like this, this is coronal cut in an endodontic case, but my orthodontic cases now consist of about 36 images, 36 views of different areas. And this is one of them. We actually cut through each tooth and lay it out in a pano fashion. And what we're looking at is not only the distance between the teeth, which we can actually measure off of these images to 1/10 of a millimeter. So if you were doing root canals, for example, you could measure your root canal file lengths right directly off this image, and you'd be dead on. Dead on. Closer than you'd ever get with any other kind of electronic apex locator or you name it. But you can see here that this is important. If you're going to move this tooth, let's say, if you wanted to move this tooth laterally to expand on an orthodontic case, it might be interesting to know where your bone is here. Because what we're finding is, I'm doing a lot of CT scans. Unfortunately, I don't have any here to show you, but I'm doing a lot of CT scans that, yeah, the teeth are straight, and they did expand, but the root's out here. The bone's over here. How many people look at views like this of their finished orthodontic cases that they expanded on? Nobody that I currently know. Nobody is. Yvonne Deuce in Italy is looking at them, and he's got about 300 cases right now on cases he expanded, and he is an excellent bioprogressive practitioner. And every single one of them are out there. We don't grow bone very well up there. These are all kid cases. These are all slow expansion cases. The teeth are great, and they all fit and so on, but the roots are out of the bone virtually, every single case. We don't expand that cortical base on the maxilla. The alveolar bone, we just burn through it as a rule. So these are actual cuts, just showing you a different view. Again, an endodontic case. You can see the root canal spaces. So you actually go down through these, you know, 1/2 millimeter, a millimeter, 2/10 of a millimeter if you want. But you can see the lesion here. in the bone. And so what we're looking at is just possibilities. So in your mind, as we're going through these lesions, you can think about what are the possibilities of what are we seeing here. Of course, airway is great. This is the best airway images in the world. We can start at the tip of the nose and go all the way down to the larynx and look at the airway all the way down through there. We don't have to guess what's going on in that kid's nose or anybody's nose. Yes, sir?
When you're doing rapid valve expansion, you do get movement of bone and part, don't you?
Yeah, you do get movement of the bone in part. You do, but it's not what we thought, because nobody's ever really looked at it. This technology is going to allow us to look at things differently than we did. I mean, we look at our case. I mean, who looks at that? Nobody looks at this. We look at, are the teeth, together and they're right, and the kid's doing fine. Nobody wants to look at this. And Yvonne didn't want to look at it, but he uses this on he diagnoses all his cases before and after. He has an enormous amount of volume of data. This is going to really. The orthodontists here are not going to want to look at this either. They don't want to look at this. So more sagittal cut views. You can see here this person actually had an RPD in their mouth. So, if this were a, and here's a lesion here, and you can see it disappears here. If this were a standard CT, you wouldn't be able to see anything in here. That RPD arm would blow out everything that the crowns didn't do themselves. You just couldn't do it with that metal in there. And because we're dentists, we always have a lot of metal where we're working of some kind. This is a case where the patient was referred. She had pain presenting in tooth number 2. She had a previous root canal about 20 years old in tooth number 3. The root canal I got this messed up here some way. Anyway, the patient had an endodontist performed a root canal in tooth number 2. The symptoms subsided for about 6 months, and then they recurred. The same symptoms came back, and so she was sent to me for evaluation. And of course, what we found was this lesion here, hiding between the roots, right here. So it wasn't visible because, and I don't care how many angles you would take that. The endodontists have these special tricks where they take 87 angles of around the tooth, and they try to figure out where the lesion is. That wasn't visible on anything. Coronal cuts again to locate the anything that you're looking at in this bone area here or up here. These are just examples here. Eudodontic study. I think I misspelled that. Right mandibular pain of elusive origin. Root canal performed on number 30 by endodontist. Pain persisted, prompting the root canal number 31, of course, which apparently was vital. And in the process of doing that, they managed to perforate the this is really magnified, so it doesn't show very well. Here's the lesion. Again, this lesion did not show up on a periapical film. Several periapical films were taken, and then they perforated the root here. There's a little lesion visible, not on this image, because as you slice through, it'll be visible on 1 millimeter, and the next millimeter it's gone. It's not there. You have to carefully observe each of these images. That's why it takes time to sit down and study these views. It's not like taking one X-ray and another happy circumstance. Left mandibular pain, elusive origin, referred by oral medicine practitioner. Number 18 was removed as the suspect tooth. A VCT revealed an endodontic lesion on the medial surface of root number 19. So there's the recent extraction site. Made a lot bigger hole, I think, than they thought it did. And the lesion is here. So keep in mind that although they look obvious here, these views were not visible, is really the point. Yeah, that's you can see the lesion here. And here's a lesion here. This was only visible in a 1 millimeter slice. And my assistant had 2 root canals done on both of her lower 7s, and pain persisted for a long time. You couldn't see anything on there, so we did a CT on her, and she had lesions on each tooth on a 1 millimeter slice only. That was it. A standard VCT 1 millimeter slice, clearly outlining the inferior alveolar canal. We're able to do a anatomical dissection of the canal and then a reconstruction of that in a pantographic format. That does not mean that this pantograph is a even slice that goes all around. In other words, the purpose is to locate anatomically, 3-dimensionally, the canal. So this is done on the computer and gives you a very good image. This was done for an implant study for a doctor. And you can see the canal here. And the lesion here that was not visible previously. It was also not visible on an earlier pantograph. But this canal is actually quite tortuous. It moves, it winds around. It's a little snake-like thing. But because of the way we can use the computer, now it doesn't distort the dimensions though. So if you measured here to here, you can measure from the superior margin of the canal to the bone height. You can measure that accurately with a measuring tool on the computer to 1/10 of a millimeter. You'll be dead on. If you so desired and felt really cocky, you could put your implant right here and you'd be fine in terms of placement. I don't think anybody in their right mind would do that off their panel lips. I hope they wouldn't do that off their panel lips. Because right now, damage to third molar, damage to mandibular canal components, specifically the mandibular nerve, is the largest single lawsuit generator in dentistry. 2 sources. One is, there are other reasons, but the main 2 are inadvertently screwing your implant through the entire canal. That's a real biggie. People really love that. And the other one is third molar extractions, which of course been around a long time. Just so you know. With a new tome CT, there's no reason to have a mandibular canal problem with either of those procedures. So these are the actual views. This is a standard CT that we used to get, and this is the new tome CT axial view, and then the transaxials 1 millimeter cuts, and that's what we give the doctor. One view. Then there's the tridimensional evaluation of airways. A lot of those of you involved in orthodontics, I guess, and many others in the room would be very interested in airway evaluation. How can you do that? And you can say this is a sagittal slice through the upper airway. You can see the adenoids completely. The combination of the adenoids and the tonsils and the inferior turbinates completely occlude this little kid's upper airway. So this is positioning the lower jaw forward slightly. See, it begins to open up the airway a little bit.
Where's the eustachian tube opening? Was it visible on that?
The eustachian tube opening was visible, yeah, but I think.
Yeah.
Yeah. Well, sort of the pharyngeal, the laryngeal area is beginning to come into view right down here. And then the eustachian tube is not visible on this screen. If you wanted to see that, what you would do is a actual cut. You would slice down through actually, you can see the entire anatomy of that area. It's not a problem at all, but not on this view. The point is, all you have to do is ask the computer to reconstruct it. You get whatever you want, or get the view you want. Also, another diagnostic challenge that has little been recognized that we don't see at all, you can see really easily on this, is the position of the inferior turbinates. What we're finding out is often it's not the tonsils themselves, but it's this posterior extent of the inferior turbinate that blocks the airway. And you're not going to see that. I mean, it's not easy to see that as a dentist. It's not easy to see it as an ear, nose, and throat. But as a dentist, we can get the view right now. We know it's there. We don't have to go up there and gag the little kid to death and, you know, look up in there. We don't have to do that. We're talking about the premaxilla and the expansion of the premaxilla. So we're able to look at these views and actually measure bony landmarks here. You can measure these bony landmarks accurately and mark them, and come back later and compare them. And this is what Ivan Duce is doing in Italy to see exactly what does happen in this area when we do our expansion orthodontics. Little cervical spine here. Nice. And so we can mark here. We can put markers here. It's very accurate and very easy to do these studies if you have the data. And we store this data permanently. So 6 months later, somebody wants some different data, a doctor wants a different view, or don't take a different look. This stuff's stored permanently. New tome surgical planning. Obviously, just a variety of different cuts. Tell us where things are. This is a third molar. You might want to know where the third molar is relative to the lingual plate, where it is relative to the nerve. What we saw on this one was that actually the mandibular nerve passed through this dentigerous cyst. So you might want to know that before you go in there and root around in there with a, whatever. You can see the lesion here. See, the canal kind of goes away, kind of disappears in there. And you can measure the precise extent of this lesion, exactly. I mean, you don't have to guess about where that thing is. You know where it is. If you're going in there surgically, you know exactly where that is. So different views for surgical planning. This is a standard kind of CT scan. You can see these are dental structures here. Notice this superior margin of the bone. Anybody want to guess where that really might be? And that's what we had to work with. So we just, we didn't measure directly from here. We just kind of guessed. And this is the pan. This is a normal CT. I mean, this is from a very this is one of the first class CT labs in Seattle. This is what you get. That's what they send dentists. Now, physicians think this is great. They love this. They say, wow, we can see everything there. Dentists are a little more picky about what they're looking at on their x-ray. We've got to see little tiny stuff. Physicians are happy if they see big lumps of stuff in there. Sinus views, great views of the frontal sinus. I mean, if there's anything there, you can see it. You can dissect through and observe the openings, the drainage routes for each sinus. You can see if they're closed or not. You can detect any swelling in the tissues, any deviation. You can detect a nice implant when it's stuck up in the sinus there like that. Just very comprehensive, and that's my point. I'm not trying to give you a course on diagnosis. I'm trying just to educate you what the possibilities were. Obviously, a mucocele here. This is the case I did for a surgeon, a patient, Middle Eastern fellow with a big kind of heavy jaw, swarthy jaw. He had a medioblastoma in his head. It'd been growing there for probably 20 years. So the surgeon wanted to know more about this tumor before he went in to take it out. And what none of the x-rays showed were these lingual perforations. So did that make any difference whether the tumor had to come out or not? Well, no, it didn't make any difference. But what the surgeon now knew, that he wasn't going to be able to stop here. He was going to have to go back in here now, because this thing was through the lingual plate as well. And we actually rotate the jaw, and we saw it in another location as well. So there were 3 perforations through the lingual plate. If you took a pan did not show this. It's a big hole, and you'd think it would show it, but it actually didn't show it. So it just gave the surgeon a heads up of what he was dealing with. This is our pan. Here's the tumor. And then when we did the new Tom CT, well, surprise. He had another medioblastoma back here. He was a medioblastoma man, we call him. This is an interesting case referred by an orthodontist who'd been watching this tooth for a year. I don't know why he was watching it. I'm not sure. It's pretty interesting, but it wasn't doing anything. So his question was, do you think I can move that tooth down here into this? So I said, no, I don't think so. So that's just a brief introduction to the new Tome technology. Coming to a new Tome center near you soon. Again, the patient benefits. As I said, I gave a lecture to a study group down in Portland a month ago, and I went down to do an hour-and-a-half presentation, and they kept me there for 4 hours, pulling up stuff off my computer, more and more cases, and more and more. And as I said, I had my presentation on orthodontic limitations, and most of them were interested in orthodontics, so that was very interesting. And this is very entertaining, huh? So there's a great deal of information here. This is just really a heads up so that you're aware of the technology. The technology is coming. This is becoming and is already recognized, I think, as the standard for dental imaging. It's not the standard of care, perhaps, in your community because you don't have one, but I know who's very interested in this. I am on the Trial Lawyers Association website in Washington, and I'm on the Trial Lawyers Association website in Oregon. I'm not on the Washington Dental Association website, nor am I on, the Oregon Dental Association website. The lawyers are very interested in this, and unfortunately, lawyers often drive medical care in our country. So they know that if they're trying to defend an implant through a mandibular canal in Seattle now, and I've been told this by the malpractice defense attorneys, there are 2 of them very close friends of mine, have worked for our local malpractice people. They don't have a chance. They used to have a chance before. Because you could say, well, the state of the art, we used the best x-ray we could, we measured, we did this, we did that, and we still stuck it through the canal. And now the person has a numb jaw and chronic pain. Now they can't do that. It's not possible. So, there's the tool. Thank you very much for your patience. Thank the Academy here for the opportunity. Any questions at all?
Yes. What if can an individual office site have the software to be able to manipulate the images when they would like to, or do you have to always go back through you as the center?
An individual office can have a couple different kinds of software. You can send printed images, and that's the way most doctors want them because they don't want to fool with anything else. They just want to look at the image. We can send a report on a CD that the doctor can read. The software for that's about $500. That's not very much. They can have it in the patient's chart. They can flip it in. They can look at any of the views that are generated for them, but they can't generate their own views. from the raw data. But they can look at the report, they can make measurements of angles and lengths and so on their own system. That doggle for that in the software is about $400. The software to read the entire system that was designed for this purpose, so you could have it in your office, is about $6,000. So we have a oral surgeon and that's interested, and a couple other people are interested. In our center, what we've done is we've designed the center so that a doctor can come down if they want to the center and actually work on our computers. They don't have to invest in that. If it's something they're going to do every now and then, you know, it really $6,000 doesn't make any sense. Plus, it takes a little time to learn to manipulate the data. And our technician is, grew up on video games, so he just thinks this is a big toy. So he can flip and fly around that thing faster than you can blink your eye. And that's the way we've managed it so far. But that is a possibility in it. And unfortunately, however, I should point out that each machine is keyed so that data cannot be sent from one. For example, you can't have a Newtome data for a machine down in Reno and me send a scan from Seattle and you read that. That's not possible, and that was done by the company. Although there is another $5,000 fix for that. Yes, George?
What is the typical cost?
I'm sorry.
How many people have you scanned to date, and what's the typical cost of the patient for some of these services?
What we're doing right now is we charge $350 for the scan, and whatever the doctor wants, we generate the images. That may change. I mean, we don't know how it's going to work. And
how many people have you scanned to date?
a lot.
1,000?
Not 1,000.
1,000, huh?
No, probably 200.
Okay.
So it's just cranking up, and to be honest with you, I mean, I spend a lot of my time now going out and just making doctors aware of this technology and how they can use it. I mean, if I say we have a CT technology, dentist goes, I saw that, didn't like that, they can't use that, what would I do with that? I don't know. But they don't even know what they don't know about being able to diagnose things. I mean, I use this. Every single patient who walks in my office, this is what I call their zero-base radiographic diagnostic image here. That's where we start. And if I need supplemental PAs, then I do supplemental PAs. But I start here. I can do great bite wings here. I mean, I can use the computer and draw a line right through the contact point on every single tooth. What better bite wing than that? There's no overlap or no anything. Any other questions?
How much space does it use in your computer?
How much space?
One scan like that.
One scan like that uses, I forget. I can't remember all that stuff. My technician could tell you right away. It's
Should be big.
I don't remember. It's a fair amount.
Yeah.
But fortunately, we have the computers have such vast storage and high speed now that it's not a problem. Storage is really something we have to keep up with. That's a bigger problem. So, yes. Yes. Yeah.
Could you talk a little bit about the project that we're working on about comparing the CAVITAT results and the CT scans for the cavitation surgery folks?
Well, we haven't done that many of them because we don't have one locally there in Seattle. But what I would tell you is that we did Ann and compared hers, and what I can tell you is that the CAVITAT is pretty well coordinated to exactly where we see the holes in the Newtome. And however, it doesn't localize it obviously as well. It can be off in Ann's. We had a couple areas were off at a whole tooth. So that's important to me because if you were going to go in purely based on a CAVITAT study, if you're going to go in to that area, you may go in there and where you think it is, but it's not there. It's actually over here, or it's lingual, or what anatomical structures does it encompass? Does it actually encompass the mandibular canal? Does it wrap around behind the tooth? I mean, what is the total three-dimensional physical shape of that and the precise location of that? So from my limited experience, if I were to get a cavitat myself, I think I'd be interested in using that as it would be a valuable screening tool that doesn't involve any radiation and no harm to the patient whatsoever. But if my plan included surgery, I wouldn't want to do that. Did that answer your question?
We have a lot of problem in our state with the dentists getting
Their license taken away.
license taken away from doing these cavitations. So for us, in the Seattle area anyway, it makes it, for the biological dentists, much more, it covers them much better for doing these cavitation surgeries, to have this CT back them up.
Thank you all so much.
Thank you.
We haven't taken special time yet this weekend to acknowledge the person who works hardest to make these meetings happen. She's ignoring us right now, but I would like to have Carol Arana stand up and for us to stand up and give her a standing ovation for her wonderful, wonderful work again this year. Thank you. It's 7 o'clock tonight. It's going to be in this room. Is that correct, Carol? 7 o'clock tonight here. 7 o'clock tonight with Jerry Tennant talking about the scanner technology again, that workshop. And in the morning we start at 8:30. It's been a great day. Thank you all.
About 460 square feet.